Hello everyone, let's have another topic in psychiatric nursing and ang pag-usapan natin ngayon is mood disorder and suicide. So everyone occasionally feels sad, low, and tired with the desire to stay in bed and shout out to the world. These episodes are often accompanied by anergia, which means that is the lack of energy, exhaustion, agitation, noise intolerance, and slow thinking processes, all of which makes decision difficult. So let's now proceed to the discussions of mood disorders and suicide. Mood disorder or affective disorder. So yan yung ating pag-uusapan ngayon for our last topic for these semifinals. So mood disorder or affective disorder is a group of disorder characterized by decreased or entire loss of control over a mood. And also mood disorder that is pervasive alterations in emotions and manifested by depressions or mania or both. So they interfere with a person's life, plaguing him or her with drastic and long-term sadness and agitations or elations. So usually accompanying self-doubts, guilt, anger, art alter life activities, especially those that involve self-esteem, occupations, and relationships. So, ibig sabihin, mood disorder, also called as affective disorder, that is a pervasive alterations and emotions manifested by depressions or mania or both. So, also interfere with life, that is a long-term sadness, agitations, and elations. From early history, people have suffered from mood disturbances. Archaeologists have found holes drilled into ancient skulls to relieve the evil humors or those suffering from sad feelings and strange behaviors. Also, in the Babylonians and ancient Hebrews believed that overwhelming sadness and extreme behavior were sent to people through the will of God or the other divine. So, until in mid-1950s, there is no treatment was available to help people with serious depressions or mania. So these people suffered through their altered moods, thinking they were hopelessly weak to succumb to these devastating symptoms. Okay, so ulitin natin, individuals with mood disorders throughout history until mid-1950s, no treatment available for serious depressions or mania. Ulitin natin din, ang mood disorder is a group of disorder that is characterized by a decrease or entire loss of control over the mood. So there are a common precipitating factor. Pwede yung loss of loved one, major life events, role strain, decreased coping resources, and physiological changes. So yan yung pwede natin mga precipitating factor why we have a mood disorder. Okay, in mood disorder, most common psychiatric diagnosis associated with suicide, uh, depressions. Because depression is one of the most important risk factor for it. For this reason, this topic focuses on a major depressions, bipolar disorder, and suicide. It is important to note that the client with schizophrenia, substance use disorder, and antisocial disorder, and borderline personality disorder and panic disorder are also at increase for suicide and suicide attempts. So, yon. So, nursing diagnosis natin, usually that is a risk for injury directed to self-directed to others. So, ang priority nursing care natin, that is the safety, our treatment of choice, lithium, our therapy, it should be non-stimulating, appropriate activity, monotonous activity, and avoid competitive. And attitude therapy natin, that is the matter of fact or kind of firmness. Categories of mood disorder. So meron tayong categories. We have the major depressive and then the bipolar disorder. In a major depressive disorder, episode lasts at least 2 weeks, during which the person experiences a depressed mood or loss of pleasure in nearly all activities. Symptoms include the change in eating habit resulting in unplanned weight gain or loss, hypersomnia or insomnia, impaired concentrations, decision making, and problem solving activities. Okay, and the bipolar disorder diagnosed when a person mood fluctuates to extreme of mania and or depressions as prescribed previously. So mania is a distinct period which mood is abnormally and persistently elevated, expansive, or irritable. So typically, this period lasts about 1 week, but it may longer for some individuals. So manic episodes include inflated self-esteem or grandiosity, decreased sleep excessive, and pressured speed. When we say pressured speed, that is unrelenting, rapid, often loud talking without pauses. And then we have hypomania. It's a period of abnormally and persistently elevated, expansive, or irritable mood and some other milder symptoms of mania. So the difference is that hypomanic episodes do not impair the person's ability to function and there are no psychotic features. In bipolar 1, one or more manic or mixed episode usually accompanied by major depressive episode, while in the bipolar 2, that is one or more major depressive episodes accompanied by at least one hypomanic episode. So these are the different types of mood disorder. So meron tayong depressions and bipolar disorder. So sa bipolar disorder natin, we have the subtypes. We have the bipolar 1 and then the bipolar 2. In bipolar 1 with history of mania. In bipolar 2, that is no history in mania. So people with bipolar disorder may experience euthymic or normal mood and affect between extreme episode, or they may have the depressed mood swing after a manic euthymic periods between extreme are quite short. For other, euthymia lasts months or even years. These are the related disorders of mood disorder. The first one, we have the dysthymic disorder, a persistent major that is a persistent depressive or dysthymic disorder is a chronic persistent mood disturbances characterized by symptoms such as insomnia, loss of appetite, decreased energy, loss of self-esteem, difficulty concentrating, and feeling of sadness and hopelessness that are milder than those of depressions. Next one, we have the cyclothymic disorder. In the cyclothymic disorder, characterized by mild mood swings between hypomania and depressions without loss of social or occupational functionings. In substance-induced depressive or bipolar disorder that is characterized by significant disturbance in a mood that is direct physiological consequences of ingested substance such as alcohol, or other drugs, and toxin. We have the seasonal affective disorder. In the seasonal affective disorder, we have two, winter depression and spring onset. In seasonal affective disorder, the first one commonly, the winter depression or fall onset seasonal affective disorder. People experience increased sleep, appetite, and carbohydrates cravings, weight gain, interpersonal conflict, irritability, and heaviness in the extremities beginning in the late autumn and abating in spring and summer. The other type called spring onset seasonal affective disorder is a less common with symptoms of insomnia, weight loss, and poor appetite lasting from the late spring or early summer until early fall. We have the postpartum maternity blues. In a postpartum or maternity blues, that is predictable mood disturbance occurring in the first several days after the delivery of a baby. Symptoms include level mood and affect, crying spells, sadness, insomnia, and anxiety. So the symptoms subsides without the treatment, but mothers do not benefit or do benefit from the support and understanding of friends and family. Next one, we have the postpartum depressions. In a postpartum depressions, the common complications of pregnancy in developed countries. So the symptoms are consistent with those depression with onset within 4 weeks after the delivery. And then we have the postpartum psychosis. In the postpartum psychosis, that is a severe and debilitating psychiatric illness with acute onset in the days following the childbirth. And then we have the premenstrual dysphoric disorder. That is a severe form of premenstrual syndrome, and it's defined as recurrent, moderate psychological and physical symptoms that occur during the week before menses and resolving with menstruations. And lastly, we have the non-suicidal self-injury. In the non-suicidal self-injury that is involved deliberate intentional cutting, burning, scraping, hitting, or interference with the wound healing. Some person who engage in self-injury sometimes called self-mutilations. Okay, let's proceed to the etiology of our mood disorder and suicide. So various theories for this etiology of mood disorder exist. So the most recent research focuses on the chemical biologic imbalances as the cause. Nevertheless, psychosocial stressor and interpersonal events appear to trigger certain physiological and chemical changes in the brain, which significantly alter the balance of the neurotransmitter. So, effective treatment addresses both biologic and psychosocial components of mood disorder. So, thus, nurses need a basic knowledge of both perspective when working with the clients experiencing this disorder. Let's start with the biologic theories. In biologic theories, in the genetic theories, first one, genetic studies implicates the transmission of major depression is the first degree relative who are at twice the risk for developing depression compared with the general populations. In neurochemical theories, which includes the serotonin, norepinephrine, possibly acetylcholine, and dopamine. So, neurochemicals influences of the neurotransmitter focus on the serotonin and norepinephrine as the major biogenic amines implicated in the mood disorder. So, the serotonin has many rules in behavior like the mood, activity, aggressiveness, and irritability, cognition, pain, and biorhythms, and neuroendocrine processes. So, the deficit of serotonin is precursor tryptophan or metabolic of the serotonin found in the blood or cerebrous fluids occurs in people with depressions. Okay, next one we have the neuroendocrine influences or the hormones. Hormonal fluctuations are being studied in relations to depression. So, mood disturbances have been documented in people with endocrine disorder, such as those who are thyroid, adrenal, parathyroid, and pituitary glands. So, the elevated glucocorticoid activity is associated with the stress response and evidence of increased cortisol, serotonin apparent in about 40% of our clients with depressions, with the highest rates found among the elder clients. So these are the biologic theories. Next one, we have the psychodynamic theories. In psychodynamic theories, many psychodynamic theories about the cause of mood disorders seem to blame the victim and his or her family. So they include the following beliefs or suppositions. So we have the self-deprecations. The self-deprecations of people with depressions become self-reproach and anger turned inward, related to either or real or perceived loss, feeling abandoned By this loss, people are then angry with while both loving and hating the lost object. Next one, we have the ideal ego. A person's ego aspires to be ideals, either good and loving, superior or strong, and that to be loved and worthy must achieve this high standard. So depression results when in reality the person is not able to achieve these ideals at all time. Next one, we have the mania as defense against underlying depressions. Most psychoanalytical theories of mania view manic episode as a defense against underlying depressions, with the id taking over the ego and acting as undisciplined, hedonistic being, a child. Depressions as reactions to life experiences. The state of depression is like a situation in which the ego is powerless, helpless, child who is victimized by the superego, much like a powerful and sadistic parent who takes delight in torturing the child. And also in the depression is a reaction to distressing life experiences such as an event of psychic casualty. Rejecting or unloving parents. Children raised by rejecting or unloving parents are prone to feelings of insecurity and loneliness, making them susceptible to depressions and helplessness. And we have cognitive distortions. In cognitive distortions, depression is a result of specific cognitive distortions in susceptible people. Early experiences shape distorted ways of thinking about oneself, the world, and the future. These distortions involves the magnification of negative events, traits, and expectations, and simultaneous minimizations of anything positive. So that is for psychodynamic theories. Okay, let's proceed to the cultural considerations. So other behavior considered age appropriate can mask depressions, which makes the disorder difficult to identify and diagnose a certain age group. Children with depressions often appear cranky. They may have school phobia, hyperactivity, learning disorder, failing grades, and antisocial behavior. While in adolescents, with depressions, many abuses, join the gangs, engage in risky behavior, or drop out of schools. While in adults, manifestation of depression can include substance abuse, eating disorder, compulsive behavior such as workaholism, gambling, and hypochondriasis. And in the older adults who are cranky and argumentative may actually be depressed. Many somatic ailments accompany depressions. These manifestations varies among cultures and may be more apparent in cultures that avoid verbalizing emotions. For example, some people may report multiple physical problems, backache, headache, or heart problem. How they are experiencing depressions may be related to cultural norms or beliefs. Okay, question. Is the following statement true or false? Depression is most commonly associated with suicide. The answer is true because the rationalized depression is considered the most common diagnosis that result in suicide. Very good. Okay, let's proceed to the major depressive disorder. So when we say major depressive disorder, that is the untreated episode of depression can last weeks, months, or years. So most clear is about 6 months. And then 50-60% will suffer the recurrence. Approximately 20% will develop a chronic form of depressions, and some people with severe depression have psychotic features. So major depression is at twice as common in women and has 1.5 to this time greater incidence in the first degree relatives than in the general population. So the incidence of depressions decreases with age in women and increases with age in men. So single and divorced people have the highest incidence. So depression is a prepubertal boys and girls occurs at equal rates. Okay, let's proceed to the psychopharmacology. Sa ating drugs for the mood disorder, we have the SSRI or yung tinatawag nating selective serotonin reuptake inhibitors. So in selective serotonin reuptake inhibitors, the most frequently prescribed category of antidepressants are effective for most clients. So their action is specific to serotonin reuptake inhibitions. This drug produces few sedating, anticholinergic, and cardiovascular side effect, which makes them safer for use in older adults. We have the TCA or tricyclic antidepressant introduced for the treatment of depression in the mid-1950s are the oldest antidepressants. So they relieve symptoms of hopelessness, helplessness, anhedonia, inappropriate guilt, societal agitations, and daily mood variations. And then we have the atypical antidepressant. In atypical antidepressants, that is used when the client has an inadequate response to or side effect from the SSRI. And then we have the MAUI. MAUI antidepressants that is have been used infrequently because of the potentially fatal side effect and interaction with the numerous drug, both prescription and over-the-counter prescriptions. In MAUI, we have the hypertensive crisis and then serotonin syndrome. Other medical treatment and psychotherapy, we have the ECT or ating electroconvulsive therapy. In the psychotherapy with combined medication, we have interpersonal therapy, which is the relationship difficulties. Behavior therapy, we have the positive reinforcement of interactions. And then cognitive therapy, focus on the cognitive distortions. And then we have investigational treatment or transcranial magnetic stimulation or TMS. So mamaya, isa-isain natin yung nating nursing implications and nursing process in terms of major depressive disorder. Okay, let's proceed to the major depressive disorder and nursing process applications. So first one, we need to do in the assessment. So in assessment, mga anak, we need to know the history, the general appearance and motor behavior, the mood and the affect, the thought process and content, and then the sensorium and intellectual processes. In the history, we nurses can collect assessment data from our client and the family or significant others. So it can be the previous chart informations and other involved in the support or care. It may take several short periods to complete the assessment because the client who are severely depressed feel exhausted and overwhelmed. So it can take time for them to process the questions, ask, and to formulate a response. It is important that the nurse or we nurses does not try to rush clients because doing so leads to frustrations and incomplete assessment of data. So to assess the client's perceptions of the problem, the nurse or we nurses ask about the behavioral changes. So when they started, what was happening when they began, their durations, and what the client has to try to about them. So assessing the history, it is important to determine any previous episodes of depressions, treatment, and the client's response to treatment. So the nurse also asks about the family history of mood disorder, suicide, or attempted suicide for the history. How about naman sa ating general appearance and motor behavior? In general appearance and motor behavior, we see the psychomotor retardations, the latency response, and then the psychomotor agitations. So many people with depression look sad. Sometimes they just look ill. The postures often slouch with head down, and they make minimal eye contact. So they have psychomotor retardation. So this is a slow body movement, slow cognitive processing, and slow verbal interaction. So the responses to the questions may be minimals with only one or two words. In the latency response naman, the client take up to 30 seconds to respond to a questions. They may answer some question with I don't know because they are simply too fatigued and overwhelmed to think of an answer or response in any detail. So our clients exhibit signs of agitations or what do you call that one? Anxiety, such as wringing their hands and having difficulty sitting still. So these clients are said to have psychomotor agitation. So pag sinabi natin psychomotor agitation, mga anak, that is increased body movements and thoughts, which includes pacing, accelerated thinking, and argumentativeness. Okay? Next one, we have the mood and affect. In the mood and affect, we see to it anhedonia. Okay? So, clients with the depressions may describe themselves as hopeless, helpless, down, or anxious. They may also say they are burdened or others are failure at life, or they may other similar statement. They are easily frustrated, angry with themselves, and can be angry with others. So they experience ahedonia, losing any sense of pleasure from activities they formerly enjoyed. So clients may be apathetic, that is not caring about themselves, activities, or much of anything. Their affect is sad or depressed or may be flat with no emotional expression. So typically, depressed clients sit alone, staring into space, or lost in thought. When addressed, they interact minimally with a few words or gestures, or maybe they are overwhelmed by noise and people who might make demand on them, so they withdraw from the stimulations of interactions with others. While in the thought process and the content naman, mga anak, usually dito naman yung ruminations, thoughts of suicides. So, yung ruminations natin, they tend to ruminate, which is repeatedly going over the same thoughts. Those who experience psychotic symptoms have delusions. They often believe they are responsible for all the tragedies and miseries in the world. So, often clients with depressions have thoughts of dying or committing suicides. Okay, it is important to assess suicidal ideations by asking about it directly. The nurse may ask, are you thinking about suicide or suicidal thoughts are you having? Most clients readily admit to suicidal thinking. Suicide is discussed more fully later in this topic. Okay? Next one, we have the sensorium and intellectual processes. Ito naman yung impaired memory. So, some clients with depression are oriented to persons, time, and place. Other experiences difficulty with the orientations, especially if they experience psychotic symptoms or withdrawn from the environment. So, assessing general knowledge is difficult because their limited ability to respond to questions. So, they have also the memory impairment is very common in this stage. So, clients have extreme difficulty concentrating or paying attention. If our client is psychotic, clients may hear the degrading and belittling voices, or they may even have common hallucinations that order them to commit suicide. Next one, we have the judgment and insights. In the judgment and insight, we focus here the impaired judgments. So, the judgment and insight, clients with depressions experience impaired judgment because they cannot use their cognitive abilities to solve problems or make decisions. They often cannot make decisions or choices because of their extreme apathy or their negative belief in that does not matter anyway. So insight may be intact, especially if the client have been depressed previously. Others have limited insight, are totally unaware of their behavior, feelings, or even their illness. Okay? Next one, we have the self-concept. In the self-concept, that is for the feeling of worthlessness. Okay. So, sense of self-esteem is greatly reduced. Clients often use phrases such as good for nothing or just worthless to describe themselves. They feel guilty about not being able to function and often personalize events or take responsibility for incidents over which they have no control. So they believe that others would be better off without them, a belief that leads to suicidal thoughts. Next one, we have the rules and relationship. In the roles and relationship, the more severe depressions, the greater the difficulty. Clients with depressions have the difficulty fulfilling roles and responsibilities. The more severe the depression, the greater the difficulty. The same is true with the family responsibilities. They have problem going to work or school when they seem unable to carry out their responsibility. So our clients are less able to cook, clean, or care for children. In addition to an ability to fulfill roles, clients become even more convinced of their worthlessness for being unable to meet life responsibility. So yon. So depressions can cause great strain in relationship. Family members who have limited knowledge about depressions may believe clients about just get on with it. Clients often avoid family and social relationship because they feel overwhelmed, experience no pleasure from interactions, and feel unworthy. So as client withdraw from relationship, the strain increases. Okay? Next one, we have the physiological and self-care considerations. Clients with depressions often experience pronounced weight loss because of the lack of appetite or disinterest in eating. So sleep disturbances are common. Either client cannot sleep or they feel exhausted and underfresh no matter how much time they spend in bed. So also they lose interest in sexual activities, and men often experience impotence. So clients or some our clients neglect personal hygiene because they lack of interest or energy. And we have in next one, we have the depression and rating scale. Clients can complete some rating scale of depression. So mental health professional administer others. So these assessment tools, along with the evaluation of the behavior, the thought process, history, family history, situational factors, help create a diagnostic picture. So self-rating of depressive symptoms include the SANG self-rating depressions. Yan, SANG self-rating depression scale and Beck depression inventory. So self-rating scale are used for case finding in the general public and may be used over the course of treatment to determine the improvement of the client's perspective. In clinician rating scale, we have the Hamilton rating scale for depressions. So ito naman, that is the clinician rates the range of the client's behavior such as the depressed mood, guilt, suicide, and insomnia. So there is also section to score journal variations, depersonalizations, that is the sense of unreality about the self, paranoid symptoms, and obsessions. Question. Is the following statement true or false? Clients with depressions often exhibit anhedonia. The answer is true. Anhedonia refers to the loss of any sense of pleasure from activities that a person formerly enjoyed. This is manifestations of depression. Let's proceed to the data analysis and nursing diagnosis. So, the nurse analyzes assessment data to determine the priorities and to establish a plan of care. So, nursing diagnosis is commonly established for the clients with depression. So, in the data analysis and nursing diagnosis, it can include the risk for suicide, imbalanced nutrition, less than body requirements, anxiety, ineffective coping, hopelessness, ineffective role performance, self-care deficit, chronic low self-esteem, disturbed sleep pattern, and impaired social interaction. So that is for our nursing diagnosis. Punta naman tayo sa ating outcome identification. In outcome identifications, for clients with depression relate to how to depression is manifested. So, for instance, whether or not the person is slow or agitated, sleep too much or too little, or eats too much or too little. So, examples of outcome for our client with psychomotor retardations, form of the depressions include the client will not injure himself or herself. So, pre-prom, self-injury. Number 2, the client will independently carry out activities of daily living. So, for example, of our activities daily living like showering, changing clothing, and grooming. Next one, the client will establish balance of rest, sleep, and activity. And also, the client will establish a balance, adequate nutritions, hydrations, and eliminations. And also, the client will evaluate self-attributes realistically. And then, the clients will socialize with the staffs, peers, families, and friends. And also, the client will return to occupations or school activities. The clients also comply with the medications with antidepressant regimen. And lastly, the client will verbalize symptoms of recurrence. Okay. Next one, we proceed to our interventions. It is important to have the interventions for our major depressive disorder. So number one is providing for safety. In providing for safety for our suicide precautions, the first priority is to determine whether the client with depression is suicidal. So if a client has suicidal ideations or hear voices commanding him or her to commit suicide, measures to provide a safe environment are necessary. If the client has the suicide plan, the nurse asks additional questions to determine the lethality of the intent and plan. So the nurse reports these informations to the treatment team. Healthcare personnel follow hospital or agency policies and procedure for instituting. In suicide precautions, for example, removal of harmful items or increased supervisions. This is a thorough discussions is presented later in this topic. Okay, important also in promoting a therapeutic relationship. It is important to have meaningful contact with the clients who have depression and to begin a therapeutic relationship. Regardless of state of depression, some clients are quite open in describing their feelings or sadness, helplessness, or agitation. So client may be unable to sustain a long interaction. So several shorter visits help the nurse, assess the status and establish. Also, we need to promote AGL and physical care. The ability to perform daily activities is related to the level of psychomotor retardations. To assess the ability to perform activities of daily living independently, the nurse first asks the client to perform the global tasks. Okay? And then we need also the using the therapeutic communications. Clients with depression are often overwhelmed by the intensity of their emotions. Talking about these feelings can be beneficial. Initially, the nurse encourages client to describe in details how they are feeling. Sharing a burden with another person can provide some reliefs. At this time, the nurse can listen attentively, encourage clients, and validate the intensity of experiences. And then another interventions, we have the managing medications. The increased activity and improved mood the antidepressant produced can provide energy for suicidal clients to carry out the act. Thus, the nurse must assess suicide risk even when the clients are receiving antidepressants. So, it is important to ensure the client in just the medication are not saving in attempt to commit suicide. And then, client and family teaching. In client and family teaching, about depression is important. They must understand that depression is an illness, not a lack of willpower or motivation. So, learning about the beginning symptoms or relapse may assist clients in seeking treatment early and avoiding a lengthy recurrence. Okay? And lastly, we need to evaluate. In evaluations, a plan of care is based on the achievement of individuals' clients' outcomes. If essential that clients feel safe and do not experience uncontrollable urge to commit suicide, participation in the therapy and medications, compliance produce more favorable outcomes for the clients with depression. So being able to identify signs of relapse and to seek treatment immediately can significantly decrease the severity of a depressive episode. Okay, let's proceed to the bipolar disorder. When we say bipolar disorder, that is involves extreme mood swing from episode of mania to episode of depressions. Okay, so during the manic phases, clients with euphoric, grandiose, and energetic and sleepless, they have poor judgment and rapid thoughts and actions and speech. During the depressed phase, the mood, behavior, and thoughts are the same in the people diagnosed with major depressions. In fact, if a person's first episode of bipolar illness is a depressed phase, he or she might be diagnosed with major depression. A diagnosis of bipolar disorder may not be made until the person experiences a manic episode. So, to increase the awareness about bipolar disorder, healthcare professional can use tools such as mood disorder questionnaire. So, yun yon. So, una, bipolar disorder, sinabi natin kanina that is extreme mood of swing. Second, only to major depression is caused worldwide disability. So, bipolar disorder ranks second only to the major depression as a cause of worldwide disability, with a risk of completed suicide for a lifetime risk for bipolar disorder at least 1.2 and risk 15% completed suicides. So, young men early in the course of the illness are the highest risk for suicide, especially those with a history of suicide attempt, especially those with a history of alcohol abuse, as well as those recently discharged from the hospital. So, most commonly, nagkakaroon ng bipolar disorder more commonly in the highly educated people. Okay, so bipolar disorder occurs almost equally men and women. It most commonly in the highly educated people because some people with bipolar illness deny their mania. Prevalence rate may actually be higher than reported. Okay, for treatment tayo, first one we have the psychopharmacology, which is the lithium and anticonvulsant drugs. In treatment for bipolar disorder involves a lifetime regimen of medications, either anti-manic called lithium or anticonvulsant medications used as a mood mood stabilizer. Okay, so lithium is a salt contained in the human body. It is similar to gold, copper, magnesium, manganese, and other trace elements. So once believed to be helpful for our bipolar mania only, investigators quickly realized that lithium could also partially or completely mute the cycling toward the bipolar depression. So, usually, yung ating lithium action fix in 30 minutes to 4 hours for regular form and in 4 to 6 hours for the slow release form. So, it crosses our blood-brain barriers and placenta and is distributed in sweat and breast milk. So, lithium use during pregnancy is not recommended because it can lead to first trimester developmental abnormalities. Okay, we have the anticonvulsant drug naman. Lithium is effective 75% of people with bipolar disorder or bipolar illness, both adults and children. So the rest do not respond or have difficulty taking the lithium because of the side effects, problems with the treatment regimen, drug interactions, or medical conditions such as renal disease that contraindicate use of lithium. So several anticonvulsants traditionally used to treat seizure disorder have proved helpful in stabilizing the mood of people with bipolar illness. So, common usually natin mga anak na anticonvulsant, we have the carbamazepine or Tegretol, which have been used for grand mal and temporal lobe epilepsy as well as for trigeminal neuralgia. And then ano pa, valproic acid, also known as divalproic sodium or sodium bivalproate, is an anticonvulsant used for simple absence and mixed seizures, migraine prophylaxis, and mania. Meron din tayong neurontin, okay, and others. So, yan yung mga sample of anticonvulsant drugs natin. Punta naman tayo sa ating psychotherapy. In the psychotherapy, it is useful in mildly depressive or normal portion of the bipolar cycles and not useful during the manic stages. So, psychotherapy can be useful in the mildly depressive or normal portion of the cycle. It is not useful naman during the acute manic stage because the person's attention span is brief and he or she gain little insight during the times of accelerated psychomotor activity. So, psychotherapy combined with medication can reduce the risk for suicide and injury. So, provide support to the client and family and help the clients accept the diagnosis and the treatment of plan. Proceed to the bipolar and nursing application or nursing process application. So, in assessment, we need also again to assess the history, the general appearance and motor behavior, the mood and affect, thought process and content, and sensorium and intellectual processes. So sa history, taking a history with the client in the manic phase often proves difficult. The client may jump from subject to subject, which make it difficult for the nurse to follow. Obtaining data in several short sessions as well as talking to a family member may be necessary. So the nurse can obtain much information, however, by watching and listening. Next one, we have the general appearance and the behavior. In the general appearance and motor behavior, need the clots reflecting elevated mood. So clients with mania experience psychomotor agitations and seem to be perpetual motions. Sitting still is difficult. The continual movement has many ramifications. Clients can become exhausted or injure themselves. In the manic phase, the client may wear clothes that reflect the elevated mood, brightly colored, flamboyant, attention-getting, and perhaps sexually aggressive. So, in the client's experience manic episode, think more and talk fast. So, nagkakaroon siya ng pressured speech. One of the hallmark symptoms is evidenced by unrelentingly rapid and often loud speech without pauses. So, those with pressured speech interact and cannot listen to others. They ignore verbal and nonverbal cues. So this indicating the others to wish to speak, and they continue with the constant intelligible or unintelligible speech, turning from one listener to another or speaking to one at all. If interrupted, clients with mania often start over again from the beginning. In the mood and affect, ang titingnan naman natin dito, the period of euphoria and grandiosity. Okay. So, mania reflected in periods of euphoria and grandiosity. Some clients manifest mania with an angry, verbally aggressive tone and sarcastic and irritable, especially when others set limits on their behavior. So client's mood is quite labile, and they may alternate between periods of loud laughters and episodes of tears. In thought process and content, circumstantially and tangentiality. Dito naman, cognitive ability or thinking is confused and jumbled with thoughts racing one after another, which often referred to as a flight of ideas. So the clients cannot connect concepts and they jump from one subject to another. Circumstantiality and tangentiality also characterize thinking. At times, client may be unable to communicate thoughts or needs in ways that others understand. In sensorium and intellectual processes, ito naman yung disoriented to time. So, intellectual functionings such as span of knowledge is difficult to assess during the manic phase. Clients may claim to have many abilities they do not possess. The ability to concentrate or pay attention is grossly impaired. Again, if a client is psychotic, he or she may experience hallucinations. Next one, we have the judgments and insight. In judgment and insight, people in the manic phase are easily angered and irritated and strike back at what they perceive as censorship by others because they impose no restriction on themselves. They are impulsive and rarely think before acting or speaking, which make their judgment poor. Insight is limited because they believe they are fine and have no problems. They blame any difficulties on others. In self-concept naman, ang titignan naman natin dyan that is exaggerated self-esteem. Clients with mania, they believe they can accomplish anything. They rarely discuss their self-concept realistically. Nevertheless, a false sense of well-being masks difficulties with chronic low self-esteem. Next one, in the role and relationship, ang titignan naman natin dito is the fulfill to roles of responsibilities. They have trouble at work or school and are too distracted and hyperactive to pay attention to children or activities of daily living. Although they may begin many tasks or projects, they complete few. These clients have a great need to socialize but little understanding of their excessive, overpowering, and confrontational social interactions. Their need of socialization leads to promiscuity. So, clients invade the intimate space and personal business of others. And then, the other one, we have the physiological and self-care medication or consideration rather. Clients with mania can go days without sleep or food and not even realize they are hungry or tired. They may be on the brink of physical exhaustion but unwilling or unable to stop, rest, or sleep. They often ignore personal hygiene as boring. When they have more important things to do, client may throw away possession or destroy valued items. They may even physically injure themselves and tend to ignore or be unaware of health needs that can worsen. So, ang ating data analysis and diagnosis, the nurse analyzes assessment data to determine priorities and to establish a plan of care. So nursing diagnosis commonly established for a client in the manic phase. So risk for others, directed violence, risk for injury, imbalanced nutrition less than body requirement, ineffective coughing, non-compliance, ineffective role performance, self-care deficit, chronic low self-esteem, and disturbed sleep pattern. And we have in the outcome identifications, example, appropriate to mania, the client will not injure or help others. Number two, the client will establish balance of rest, sleep, and activity. Next one, the client will establish adequate uh, nutrition, hydrations, and eliminations. And also the clients will participate self-care activities. And also the client will engage socially appropriate reality-based interactions, and the client will verbalize knowledge of his or her illness and treatment. Okay, question. Which would be the most appropriate for the treatment of mania associated with bipolar disorder? A. Lithium, B. Fluoxetine, C. Citalopram, or D. Venlafaxine? The answer is A. Lithium, because when we say lithium is anti-manic agent which would be most appropriate for treating a manic client with bipolar disorder. So the other choices is antidepressant. Okay? Let's proceed to the interventions. Parehas din lang siya doon sa ating major depressive. The interventions focuses on the following: the providing for safety, meeting physiological needs, providing therapeutic communications, promoting appropriate behavior, managing the medications, and providing the client's family and teachings. So in providing for safety, because of the safety risk that clients in the manic phase take every play a primary role in care followed by issues related to self-esteem and socialization. So the primary nursing responsibility is to provide safe environment for clients and others. So the nurse clients assesses the client's directive for suicidal identifications and plans or thoughts of hurting others. So, also in addition, clients in the manic phase have little insight into their anger and agitations and how their behavior affects the others. In the meeting physiological needs, clients with mania may get little rest or sleep even if they are on the brink of physical exhaustion. Medication may be helpful, thought clients may be resist taking it. Decreasing environmental stimulation may assist clients in relaxing. So the nurse provides a quiet environment without noise, televisions, or other distractions. So establishing a bedtime routine such as tepid bath may help clients calm down enough to rest. And also nutrition is another area of concerns. Okay? So manic clients may be too busy to sit down and eat, or they may have such poor concentrations that may fail to stay interested in food for long. So finger foods or things clients can eat while moving around are the best options to improve nutrition, such as food should also be high in calories and protein as possible. In providing therapeutic communications, clients with mania have short attention span, so the nurse uses clear, simple sentences when communicating. They may not be able to handle a lot of information at once, so the nurse breaks information into many small segments. It helps to ask clients to repeat brief messages to ensure they have heard and incorporated them. So, yon. Next one, we have the promoting appropriate behavior. These clients need to be protected from their pursuit or socially unacceptable and risky behavior. So the nurse can direct their need for movement into socially acceptable large motor activities such as arranging chair for a community meeting or walking. In acute mania, the clients lose the ability to control. So their behavior and engage in risky activities. So because the acutely manic clients feel extraordinarily powerful, they place few restrictions on themselves. So they act out impulsive thoughts, have inflated and grandiose perception of their abilities, demanding and need immediate gratification. In managing in managing medication, lithium is not metabolized. Rather, it is absorbed by the proximal tubule and excreted in the urine. So, periodic serum lithium levels are used to monitor the client's safety and to ensure that the dose given has increased the serum lithium levels to treatment level or reduced into the maintenance level. Okay? And then we have the providing clients and family teachings. Okay. Educating clients about the danger of risky behavior is necessary. However, clients with acute mania largely fail to heed such teaching because they have little patience or capacity to listen. So, understand and see the relevance of these informations. Clients with euphoria may not be see why their behavior is problem because they believe they can do anything without impunity. As they begin to cycle toward normalcy, however, risky behavior lessen and they become ready and able to for teaching. So many clients start many tasks, create many goals, and to carry them all at once. Education about the cause of bipolar disorder, medication management, ways to deal with behavior, and potential problems that manic people can encounter is important for the family members. Also, family members often say the client have stopped taking of their medications when. Okay, so for example, clients become more argumentative, talk about buying expensive items that they cannot afford, hotly deny anything is wrong, or demonstrate any signs of escalating mania. Okay, the client should learn to adhere to established dosage of lithium and not to omit doses or change dosage intervals. So, unprescribed dosage alteration is interfere with the maintenance of the serum lithium levels. And lastly, client may and family members should know the symptoms of lithium toxicity and intervention to take, including the backup plans if the physician is not immediately available. So, the nurse should give this in writing and explain to the client's family. And lastly, evaluations. In evaluations, the treatment of the bipolar disorder includes but not limited so safety issues, comparison of mood and affect between start and treatment and present, adhere to treatment regimen of medication and psychotherapy, changes in clients' perceptions of quality of life, and achievement of specific goals of treatment, including the new coping methods. Okay, punta naman tayo sa suicides. When we say suicide, that is intentional act of killing of oneself. Okay, so suicidal thoughts are common in people with mood disorder, so especially the depression. So usually men commit approximately 72% of suicides. Okay? And then suicidal ideation natin, thinking about killing of oneself. So, intentionally trying to commit suicide and self-injury behavior are often different concept. However, it is a crucial to remember that one does not exclude the other. So, however, it is crucial to remember that one does not exclude the other. So, person who self-injure can and do commit suicides. It is important to assess both and never think someone is safe from the suicide because they are typically self-injured. So client with psychiatric disorder, especially the depression, bipolar disorder, schizophrenia, substance abuse, post-traumatic stress disorder, and borderline personality disorder are increased or risk for suicide. So, meron din yung chronic medical illness associated with increased risk for suicide includes the cancer, HIV or AIDS, diabetes, cerebrovascular accident that increase suicide risk include and spinal cord injury. So, meron din tayong environmental factors. So, pwede rin yung increased suicide risk o yung include isolation, recent loss, lack of support, unemployment, critical life event, ano pa, family history of depression or suicide. And another one, we have the behavioral factors that increase impulsivity, erratic or unexplained changes from usual behavior and unstable lifestyle. Punta naman tayo sa suicidal ideations. That is means thinking about killing oneself. So, active suicidal ideations is when the person think about and seek ways to commit suicide. So, passive suicidal ideation is when a person thinks about wanting to die or wishes he or she were dead but has no plan to cause his or her death. People with active suicidal ideations are considered more potentially lethal. We have also the attempted suicide. In attempted suicides, a suicidal act that either failed or was incomplete. In incomplete suicide attempt, the person did not finish the act because someone recognized the suicide attempt and responded. Or the person was discovered and rescued. So suicide involves ambivalent. Many fatal accidents may be impulsive suicide. So it is possible to know, for example, whether the person who drove into a telephone pole did not intentionally. So hence, keeping accurate statistic on suicide is difficult. Okay? So suicide involves, sabi ko nga kanina, that is for ambivalence. And yon. So there are warning signs for our suicide risk. So, pwede. Ang mga myths and facts regarding suicide. For example, people who talk about suicide never commit suicide. So, that is for myths. Ang fact niya doon, suicidal people often tend out of subtle or not too subtle message that convey their inner thoughts or hopelessness and self-destruction. So, both subtle and direct messages of suicide should be taken seriously with appropriate assessment and intervention. Okay, let's proceed for our nursing process or nursing applications. So first one in suicides. Assessment. A history of suicide attempts increases risk for suicide. So the first 2 years after an attempt represent for the highest risk period, especially the first 3 months. Those with a relative who committed suicide are increased risk for suicide. The closer the relationship, the greater the risk. One possible explanation is that relative suicide offers a sense of permissions or acceptance of suicide as a method of escaping a difficult situation. So the familiarity and acceptance is also believed to contribute to copycat suicide by teenagers who are greatly influenced by their fear actions. Okay? So ulitin natin. Previous suicide attempts, the first 2 years after the highest risk period, especially the first 3 months. So, relative who committed suicide. Okay, punta naman tayo sa warning of suicidal intent. Most people with suicidal ideations send either direct or indirect signals to others about their intent to harm themselves. So, often, people contemplating suicide have ambivalent and conflicting feelings about their desire to die, and they frequently reach out to others for help. So, asking client directly about thoughts of suicide is important. Psychiatric admissions, assessment, interview forms routinely include such question. It is also standard practice to inquire about the suicide or self-harm thoughts in any setting where people seek treatment for emotional problem. In risky assessments, or risky behavior rather, a few people who commit suicide give no warning signs. Some artfully hide their distress and suicide plans, so others act impulsively by taking advantage of a situation to carry out the desire to die. Some suicidal people in treatment describe placing themselves in risky or dangerous situations, such as speeding in a blinding rainstorm or when intoxicated. This Russian roulette approach carries a high risk for harm to clients and innocent bystanders alike. It allows clients to feel brave by repeatedly confronting death and surviving. Next one, we have the lethality assessment. When a client admits to having a death wish or suicidal thoughts, the next step is to determine potentially lethality. This assessment involves asking the following questions. So, for example, does the client have a plan? If so, what is it? Is the plan specific? Are the means available to carry out this plan? If the client's carried out the plan, it's likely to be lethal. Has the client made preparation for death? Or when does the client intend to carry out the plan? Is the intended time a special date or anniversary that has meaning for the client? So a specific and positive answer to these questions increase the client's likelihood of committing suicide. It is important to consider whether the client believes his or her method is lethal even if it's not. Behaving a method to be lethal poses a significant risk. Let's proceed to the outcome identifications and examples. So, suicide prevention usually involves treating the underlying disorders such as mood disorder or psychosis. With the psychoactive agents, the overall goals are first to keep the client safe and later to help him or her develop new coping skills that do not involve self-harm. So other outcomes may relate to the activities of daily living, sleep and nourishment needs, and problem specific to the crisis such as stabilization of psychiatric illness or symptoms. So these are the example of our suicidal person's outcomes. So the client will be safe from harming self and others. The client will engage in a therapeutic relationship. The client will establish no suicide contact. The client also create a list of the positive attributes, and also the client will generate, test, and evaluate realistic plan to address underlying issues. In interventions, we need the first one we have using authoritarian role. Intervention for suicide or suicidal ideations become the first priority of our nursing care. The nurse assumed an authoritative role to help client to stay safe. In these crisis situations, clients see few or no alternatives to resolve their problems. The nurse let clients know their safety is the primary concern and takes precedence over other needs or wishes. For example, a client may want to be alone his or her room to think privately. This is not allowed while he or she is an increased risk for suicide. Next intervention, we have providing a safe environment. Inpatient hospitals, units have policies for general environmental safety. Some policies are more liberal than others, but all usually deny clients access to materials on cleaning carts, their own medication, sharp, scissors, and pen knives. Kasi for suicidal clients, staff member remove any item they can use to commit suicide, such as the sharp objects, shoelaces, belts, lighters, matches, pencils, pens, and even clothing with drawstrings. Again, institutional policies for suicide precautions vary, but usually staff members observe clients every 10 minutes if lethality is low. Next one, we have the creating a support system list. Suicidal clients often lack of social support systems such as relative and friends or religious, occupational, and community support groups. So this lack may result from social withdrawal, behavior associated with psychiatric or medical disorder, or movement or change in a family structure or financial status. The nurse assesses support system and the type of help each person's or group can give a client. So mental health clinics, hotlines, psychiatric emergency evaluation services, student health services, church groups, and self-help groups are part of the community support system. So the nurse makes a list of specific names and agencies that the clients can call for support. He or she obtains client consent to avoid breach of confidentiality. So many suicidal people do not have to admitted to hospital and can be treated successfully in the community with the help of these support people and agencies. Okay, the family response. In the family response, we need to have suicide as a ultimate rejection of family and friends. Families react with guilt, shames, and anger, and families can disintegrate. So, suicide is the ultimate rejections of the family and friends, implicit in the act of suicide, in the message to others that their help was incompetent, irrelevant, or unwelcome. So, suicides are done to place blame on a certain person, even to the point of planning how that will be the one to discover the body. So, significant others may feel guilty for not knowing how desperate the suicidal person was. So, angry because the person did not seek their help or trust them. So, ashamed their loved ones ended his or her life with a socially unacceptable act, and sad about being rejected. So, suicide is newsworthy, and there may be whispered gossip and even news coverage. So, life insurance companies may not pay survivors benefits to families of those who kill themselves. Okay? So, punta naman tayo sa ating nurse's response. In the nurse's response, need for unconditional love, positive regard for a person's, avoidance of client blame, non-judgmental approach, tone, belief that one person can make a difference in another life, and possible devastation of staff in a client commit suicide. So, yon. Next one, legal and ethical considerations. So, assisted suicide is a topic of national and legal ethical debate. So, in Oregon was the first state to adopt assisted suicide into the law. So, nurses often care for terminally and chronically ill people with poor quality of life. So, nurses' role is to provide supportive care for clients and family as they work through the decision-making process. Is the following statement true or false? When dealing with a client who is suicidal, the nurse needs to assume the dependent role. That is false. When dealing with a client who is suicidal, the nurse must take an authoritative role. Okay, elder consideration natin. Depression's common among elderly. So, marked increase when elders are medically ill. So, psychiatric features more frequent in younger people with depressions. Increase in tolerance of side effect of medications. ECT are commonly used for treatment, more rapid response, and suicide increasingly among elderly. Community-based care, nurses are first health professional to recognize the behavior consistent with the mood disorder. Documenting and reporting behavior help clients get treatment. And successfully treatment of depression in community by psychiatric advanced practice nurses, and primary care physicians. Mental health promotions. In mental health promotion, education to address stressor contributing to depressive illness. Okay. And then efforts to improve primary care treatment of depressions, and then preventions and early detection treatments for our adolescents. Screening for early detections of risk factor, we have the family strife, parental alcoholism or mental illness, history of fighting, access to weapons into the home. Self-awareness issues, importance of dealing with own feelings about the suicide. Frustrations possible when working with depressed or manic clients. Exhaustion possible when working with manic clients. Journaling to help dealing with feelings, and talking with colleagues is often helpful. Okay, that is for our mood disorder and suicide. So that's it. And thank you and God bless. Thank you for listening. Have a nice day.